Is that good?
Yeah, it's gonna go on, yeah, about
That's
20
good.
seconds.
That's fine.
Okay.
Yeah, we're good. Deep breath. All right.
Dr.
I'm good to go whenever. Okay. All right, my name is Kyle Brown, for people who don't know me. I did my presentation on a patient that I saw in my last 16-week clinical in an acute care setting. The title of my presentation is Treatment of Lower Extremity Paralysis in a Patient with Epidural Abscess in the Acute Setting. So the purpose of my presentation was to assess the changes in functional mobility and lower extremity muscle activity in a patient with lower extremity paralysis undergoing physical therapy in the acute setting. So just a little bit of history about my patient. She was a 48-year-old Caucasian female, past medical history of chronic kidney disease, osteoporosis, chronic low back pain, depression, history of hepatitis C, alcoholism, benzodiazepine, and hydromorphone use. She was a smoker, and she, at present, was an illicit IV drug user, when she came to me in the clinic. So she presented February 18th to the emergency department with back pain and lower extremity weakness that quickly progressed to bilateral lower extremity paralysis. She was diagnosed by MRI with an epidural abscess from T3 to T7 with associated cord compression and underwent emergency T5 to T7 laminectomy and drainage. So just quickly about the epidural abscess, it's like a pocket or like a collection of infection or inflammation that can get in between your cranium and your skin, or also between your vertebrae and your dura mater of your spinal cord. So that's what she had, obviously, was the spinal epidural abscess. And normally, to treat it, you would obviously drain it, and if in this worst case scenario, you would do the laminectomy and drainage, so it was pretty significant. She had physical therapy before I saw her, and she was discharged to a skilled nursing facility, but she ended up coming back on March 4th for a benzodiazepine overdose. I'll get into this a little bit later, but her family dynamic was not good. They had brought her like a whole prescription of Xanax in a Doritos bag, and then brought it to the facility without their knowledge, and then she overdosed on it while she was there. They found her unresponsive, and then that's when they brought her back to the emergency room. So technically, the reason she was there at that time was for the overdose, but all that other stuff still applied. And also, before I saw her neurology consulted with her, she had bilateral ankle clonus. It was around like 1 beat. And she also had, but she did have intact light touch sensation and like deep pressure sensation. So, and it didn't really say anything about abnormal reflexes or anything like that, other than, well, I guess it would be abnormal if they was 0. So, but so that was, I guess, what I had before then. Especially in the hospital, we get a lot of documentation. So, I did have a lot of that to look at. Saw the MRIs and everything too. So, so the first part of the examination, we did a little bit of the social history. She lived alone by herself in a mobile home with 4 steps to enter. She was independent with basically everything, driving, everything before we saw her. And I also learned that she had a 26-year-old son that had recently committed suicide. So like I said, her family dynamic was just not very good. And that was definitely one of those things that I had to consider during the line of care also. So for the examination, some pertinent findings. She was 3 to 4 out of 10 pain in her upper back, bilateral traps basically. I just think she was trying to overcompensate with the upper extremities, but it wasn't really detrimental to any of our treatments or anything like that. She did have intact bilateral light touch sensation, which was agreeing with the neurology consult. I did do proprioception on her toes, and she was also within functional limits for that. Passive range of motion was functional, but the active range of motion, left lower extremity, she was able to dorsiflex slightly. She was able to have a little bit of hip and knee flexion against gravity, but her right lower extremity was basically trace muscle activity, not even based, some occasional like toe movement, but I don't even think that was necessarily voluntary, or she couldn't really control it very well. So for the strength on her right lower extremity, it was 1 out of 5. Left lower extremity was 2+. And I did check ankle clonus as well, and it was greater than 5 beats on both sides. So the spasticity, I guess, or the clonus had gotten worse since the neurology consult. And in the acute care, you just are checking basic functional mobility just to assist with case management and everything with discharge locations and stuff. So just the basics there for the functional mobility. She was med assist for rolling, max assist for supine to sit, mod assist for sit to supine. She was assist +2 for the lateral scoop transfers with using a slide board. We didn't attempt ambulation on the initial examination. And she was also supervision admin for static and dynamic sitting. We did have to abide by her back precautions. So she did have a laminectomy, and our facility's policy/protocol is to abide by the no bending, lifting, twisting, the basic back precautions. So we did use a log roll technique for bed mobility. And for the lateral scoop transfers, she exhibited like a really quick posterior loss of balance with her lateral scoop transfers. So we were going to assess that, obviously later on into the subsequent treatment. So putting it all together, I guess, using the HIPET model, her health conditions, epidural abscess, associated cord compression, the impairments that we were really wanting to focus on going forward, bilateral low extremity weakness, her decreased trunk balance, and the assistance that she needed with functional mobility. And that all that would help, I guess, get her back home is what the ultimate goal was. But and just a couple other things here. I won't go through everything. I did touch on her negative family dynamic and her history of IV drug use. And she was also very biased against her SNF rehab. Basically what happens when they found out that she had unprescribed medications, they kicked her out, and she was never allowed to go back to that SNF ever again. And we basically had to reinforce her the whole time that SNF rehab isn't necessarily a bad thing. Some of them might not be as good as others, but it's what you kind of make of it. So we had to battle with her about that the whole time because obviously at her current level, living by herself, she was not going to be able to go home. So it was either skilled nursing or inpatient rehab. So we did have like a wing of that off. I do touch on that a little bit later, but I'll go ahead and say that. So before I got to her, inpatient rehab was consulted multiple times, and she was denied like 3 or 4 times before I even got to her. So what their procedures, I guess, are is they just need to have a strict, like, set in stone discharge location. And I guess she wasn't 100% sure where she was going, so that was basically like an automatic denial from inpatient rehab. So I guess what the choices were was the SNF and to go home, which is what we did want. And she was also denied by about 20 skilled nursing facilities while we were there. So basically the whole time we were there, which is about a week and a half, they were trying to place her somewhere. So given all that, plan of care, the interventions we were doing, we were trying to focus on incorporating lower extremity strength, getting some muscle recruitment, muscle activity going, working on the trunk balance and her functional mobility. So we thought she was going to be there around 2 weeks. She ended up being there about a week and a half. But we set 2 goals for her: bed mobility with standby assist, lateral scoop transfers with standby assist. We didn't use a formal outcome measure. I'll get to that later. But we used the gross strength testing that we had during the exam and the functional mobility assistance levels that we had. And for the frequency, based on our caseload, we were basically in charge of about 2 floors worth of evaluations and treatments. So their protocol kind of was to do about 3 times a week unless something had changed or something was different. And then her ultimate DC location that we were thinking of was the skilled nursing. Are there any questions so far about anything that I've gone over so far? Yes?
How long were you sitting here for?
How long?
Treatment sessions.
Oh, like I said, I will get into that a little bit later too, but usually a treatment session was about 45 minutes to an hour tops would be the most we would ever spend with her. So
I know you said she lived alone. Did she have anybody that could have come and checked on her, helped her
So-
out, or?
And that was, obviously the questions that we asked during the exam, but she couldn't give a definite answer, and a lot of the family stuff that was going on wasn't very good to begin with. So I think our ultimate decision too was it would have been better off to go to a skill for a little while at least. Any other ones before we go? All right. So the next part is just kind of focus on the treatment that we were going to do. So I said initially that we were going to try to, so basically I tried to do like a lot of motor recruitment stuff, a lot of, just getting some muscle activity in those legs just to see if we could wake them up anytime. So we did a lot of the same things. We did a lot of repetition. I was looking in the research, there were certain things about standing and active range of motion, but it was saying in the research that repetition really helps with like muscle activity and stuff like that. So we did the active assisted range of motion probably about every day. And there was an article by Kawahira that said that intensive repetition of these types of active assisted range of motion, like dorsiflexion, plantarflexion, and supine, knee flexion extension, sitting, and in supine, so any of those like facilitatory techniques, they helped with voluntary movement or voluntary contraction of the muscles. So I was going to hit that basically every day. And the first day we also did bridging. I looked at an article where it was saying that a bridge exercise really is good at recruiting the erector spinae muscles and the multifidi muscles. So any kind of muscle activity or recruitment, I was happy with. So, and it also said that the bridges are good at co-activation and not giving any external load to the trunk, so you can really work on some of that stabilization. And that would also be beneficial for her trunk balance and all that stuff too, just to help her core. And the same thing with the functional mobility training. I did that in active range of motion, and later on standing just about every day that we were there. But we ended up only seeing her probably about 5 days. So, but just some highlights from day one. She had intact sensation, but she was not aware when she had bowel movements. So she had bowel movements multiple times during every session. And, I was a young man and my CI was a man and she was a 48-year-old woman. So we felt more comfortable having, the female CNAs going in there and kind of taking care of that. But that really decreased the amount of time that we had to spend with her some of those days. And she was also still exhibiting a lot of that poor trunk control. So it was still a lot of the heavy posterior lean backwards. She wasn't controlling it very well. And we progressively saw her left lower extremity getting better, faster than the right. So she was increasing her range of motion and her strength in her left lower extremity, but she's still not really getting much other than an active or kind of like a trace muscle contraction in her right side. So day 2, more active assisted range of motion. And we did do a lot of the dynamic sitting with the reaching tasks. Really educated her on correct posture because one of the other articles that I read said that if you have erect posture, it actually increases the activity of the erector spinae and the multifidi more than you would if you were like in a slumped posture. So while we were doing these dynamic reaching in multiple planes, we were really trying to get the correct posture because that's going to help facilitate more muscle activity. So highlights from day 2 as well, multiple bowel movements again. So that was kind of a hindrance and embarrassment for her, but we took it in stride and had to deal with it. But she was showing better trunk control after day 2 with the functional mobility training. Still showing a little bit of the wobble and instability there, but it wasn't anything like the examination where she was just flinging back and about to hit her head on the bed. And her left lower extremity strength got to about a 3. So she was able to do basically all that active range of motion with her left side against gravity, but we didn't really push it with any of the resistance or anything that day. Oh, and I didn't talk about standing frame. So the big thing I wanted to try to get was standing, getting that co-activation of the muscles, getting her blood flowing, getting her body used to being up on her feet. Because basically the only time she really got out of bed was when we were there. Because she's a heavy assist to get out of bed over to the chair, and that she was not happy to see anybody else but us. I don't know what the whole reason for that was, but she wasn't complicit with basically any other discipline other than physical therapy while we were there. So she didn't do much movement. So standing frame, we had one standing frame in the whole facility, so we took like 30 minutes to get over there with it. And, stood for about 6 to 8 minutes, but she still complained a lot of the trap, like soreness and just fatigue. So we had the tray that she could kind of sit her hands on, just to maybe kind of take away from some of that. But I did read some good articles about standing and the standing frame. Actually, there was an article by Bernhardt that actually looked at how much weight you're putting through your feet while you're in a standing frame. And it was saying, with the hands by your sides, you're 85% of your body weight going through your feet when you use the standing frame, but it goes down by 10% when you have your arms up on the tray. So that's what they had found there. So some of the other articles for standing was basically saying, I wasn't doing this for this benefit, but she did have a history of osteoporosis, and I was seeing a lot of articles out there about standing actually increases bone marrow density in the legs and stuff like that. So that was kind of an extra tidbit that we used, but wasn't necessarily doing it for that reason. And there was another article by DeLeon that said basically the same thing I was saying earlier, like repetition. So it was saying repetitive standing kind of helps with motor learning of the spinal cord to help when you're actually repeating a task like that, that it actually would help you weight bear more and use your muscles a lot more too. So, and it was saying more of like weight bearing in an extended position. So like a standing position actually helps with motor recruitment also. So I figured the standing frame was probably the way to go. So we just was going to hammer that for the 5 days. But then day 3, it broke while we were there. The only standing frame we had, and it didn't work. So we kind of had to modify a little bit. So I did basically like the double blocking of the knees, and I actually kind of just stood her up on my own and just had her like holding her hands on my shoulders. Kind of at least just getting up the stand, and she was able to do it for about 45, 60 seconds, and we did that for 4 to 5 sets. So we're not as much time as the standing frame, but it was also a little bit better as well. So, and we had my CI was down there kind of helping control the knee, so it wasn't in any hyperextension because she tended to do that for passive stability. So we were flexed a little bit, but we're trying to get that co-activation and working all the muscles. Functional mobility again. And then day 3, we actually saw a little bit of gain with muscle activity in her right lower extremity. She was able to wiggle her toes voluntarily and get some dorsiflexion on her right lower extremity. So that doesn't seem like a big deal, but she was crazy thrilled about that. Like, she didn't want to go anywhere else. She said that she wanted us to be her therapist forever. But and I was just telling her that stuff like that was going to happen in the SNF, just help reinforce everything. And she was progressing to contact guard for her lateral scoop, so she was getting a lot better with the trunk as well. And given the gains with the muscle activity and everything, I went up to 4 times a week, even though that kind of put us a little bit behind on our caseload sometimes. But I figured we just needed to have more time up on our feet, more time doing some of that stuff as well. So the whole time we were in communication with the case manager. So in the acute care, that's really the first time I've been had that kind of communication with a provider. So they're really good resources as far as discharge locations and talking to the family. But she was, as you know, she was having a hard time placing her. She wasn't getting accepted to inpatient rehab. She got denied by over 20 places. So nobody was really sure where she was going to go. So we kind of focused our plan of care more toward independence, as much as independent as you could be. So we started educating her on like self-assist techniques for rolling, hooking the good leg over the other leg, using a towel for range of motion and stretching. And we also did the dynamic sitting again with the reaching, still seeing some improvement there, and then hitting the functional mobility. And we also saw that her right hip adductor activation was actually coming about. So she was actually able to move the right leg, adduction, but she needed help with the abduction, but she was able to do it, gravity eliminated, obviously. But so we're still seeing some increases, not as big as I would have liked probably, but we were still seeing some progress. Day 5 ended up being the last day. We didn't know that. It was a Friday. We didn't know if she was going to be there over the weekend, but she ended up, well, we'll get to that later. But the last thing that we did kind of that really changed things was on day 5, we did a lot of like lateral rocking when we were standing. And I was reading an article that was basically saying like unloading one of your lower extremities and then putting load back onto it helps increase the proprioceptive input and increases the recruitment and the ability to get co-activation. So we did that for the last day. And she was getting, decent, I guess, knee stability. We were still had probably like assistive too to help with the knee. And we worked on wheelchair mobility. So when we did the functional mobility training, we would transfer over to the wheelchair and then have her, roll around in the wheelchair a little while just to see what her functional mobility would be if she did go home. So the outcome measure thing that I said earlier, I was trying to think of one, but most of the ones that came to my mind were ambulatory ones with standing balance and stuff like that. But I remember the function and sitting test. So I was like, hey, we're going to do this. She scored a 40 out of 56. 56 would be the 100% on it. So she was pretty good. And then that was the last day. So we couldn't do it again. And the function and sitting test does not have any norms or cutoff scores. So really the only thing that was beneficial is if you do it multiple times to see about the MCID, or the minimal detectable change. But we ended up only doing it once because she left that weekend. The highlights as well, dorsiflexion getting better on the right side. She was able to adduct with the right lower extremity through almost full range, still gravity eliminated. And I kind of touched on that as well about the compliance with physical therapy. I think it was, because we tried to get to know her as a person and tried to, we spend, a lot of times as PTs, we spend more time with the patients than anybody does other than nurses. So you get to know your patients, and I think she was comfortable with us and she was seeing, results. So she wanted to see us every day. And we just told her we couldn't see her every single day, but, but the nurses were kind of surprised at how receptive she was to us, but then she was just not very nice to anybody else. So over the course of the examination and the 5 treatment days, changes in outcome measures. Right lower extremity went from 1 to 2 minus, so basically a trace muscle contraction to being able to move through almost full range, gravity eliminated. So we weren't able to get full range gravity eliminated. And then the left lower extremity seemed to be progressing a lot better than the right. So she was able to get to at least 3. So, and as far as the functional mobility assistance levels, I won't read the exam again, but at DC she was mod I for rolling, min assist for the other bed mobility, and basically supervision for transfers with the slide board and for dynamic and static sitting balance. But she was still a pretty heavy assist for sit to stand. And to maintain the sit to stand, or to maintain the stand, she was, assistive too. So at discharge, her bed mobility was partially met because she needed min assist still for the supine to and from sit. She was mod I for the rolling. She met the lateral scoop transfer goal. And her DC location, she did go to a skilled nursing facility, but it was on a 30-day contract. So she had to be there for 30 days. And then I don't really know what else happened after that. She just kind of left on the Saturday. And, but I have a slide here about the considerations that I had to, think of during the plan of care. We had to think about the change in treatment frequency. So I did that because she was progressing. I could see her progressing. And we also did that too because we weren't sure of where she was going to go. And if she was going to go home, she really wasn't prepared for going home. So we try to spend a little bit more time on that. Obviously, the equipment failure was a little bit of an issue. And I did touch on the DC planning, but multiple denials with inpatient, problem with SNF. She really didn't like the SNF setting, so we really did a lot of reinforcement. We had to kind of change our plan of care to the self-assist, wheelchair mobility, kind of the independent aspect of things, just in case she didn't go home. So some of the limitations of the case, we did have a limited number of treatment days, but that kind of comes with the acute care setting, and the limited number of time during some of the treatments because of the bowel movement issue. And I touched on the questionable discharge location. And I also did see a lot of research on like electrical stimulation for muscle activity and increasing muscle recruitment and stuff like that. But we didn't have any of that stuff at the facility, so I wasn't able to use any of that, but there was some research backing that. So if we did have an opportunity, that could be something we can incorporate. So what I would do differently, I would use the function and sitting test during the exam. I would have thought about that more and come up with that sooner. And I would also focus more on the independent aspect of things a little bit sooner. We only could do it for the last day and a half or so of treatment. Like I said, we were in constant communication with the case manager. And I probably would have liked to kind of move in that direction a little bit earlier, even though she did go to a SNF at the end. Still wanted to be prepared for that. So that's all. Anybody have any questions?
First of all, I thought it was a fantastic case, very well researched. I learned so much just listening, so thank you for all your hard work and advocating for this lovely lady. In your travels, as you treated this patient, in addition to the case manager, did you have any interactions with the physician or other members of her team on a regular basis, and what did that look like? And did you feel comfortable doing?
So I would probably say with her, we didn't really have a whole lot of communication other than the nursing and the CNA and the case manager, but there were other patients that we had to get clarification on and stuff, but not according to the case. But I did spend some time speaking to physicians and stuff like that. So that kind of was a newer situation for me as well, but I got used to it. And but not particularly with her, but with other patients, I did have the opportunity to do that as well.
So it sounds like you had a really good relationship with her and she liked you a lot. Did you use that relationship at all to kind of talk to her a little bit about her history with drugs and alcohol? It's always been a tough thing, but with that kind of relationship, I was just wondering.
Yeah, and we did have a good relationship, but I didn't really delve into that a little as much as I probably could have. But I did have a coworker that worked with her the last time she was there. And she was supervising me for one of the treatments that we were there too. And she told me that she had an active, communication with her about stuff like that she had the opportunity to talk to her on that kind of level. But I didn't necessarily feel comfortable, I guess, at that moment doing that. But she was having somebody in her ear kind of talking to her about stuff like that. So. Anybody else? Yes, sir.
So, nicely done overall. Really, I like the thought of bringing the objective measure again and saying, center.
Yeah.
And be able to notate that progress. What medically were they doing that kept her there on that wall?
All right. So, I guess they were trying to make sure she was stable enough to go somewhere, first of all, with the overdose. It said in the documentation that it was an accidental overdose, but everything I read was like accidental. So, but and also with the epidural abscess, it's either a 6-week or a 12-week trial of IV antibiotics that they use. And she was still currently on that while we were treating. I could have said that as well, but she was on the IV the whole time. She was on a Foley catheter the whole time. She didn't really have anything else going on. No orthostatics, no problems with that much pain. No really issues with her vitals as much. Her blood pressure was a little bit low. I think it was because of some of the medication she was on. A little dehydrated probably, but I think the biggest thing and why she stayed there the longest time was because they were trying to find placement for her. But the SNP that she went to knew about the antibiotics, obviously, and knew they were going to have to take that on. But to my knowledge, the only thing really that was keeping her there was what they also did recheck a couple times, like the MRIs, to see if they had any spread of infection or if they got the infection. So they did do a lot of blood cultures as well. But I didn't see any abnormalities or anything like that. It's just, I think she was kind of in holding until they found something. But she was on IV antibiotics for like a 12-week stint, I think. So
I feel like that was contributory to her bowel movements, or was she,
I was fixating. I didn't consider that a whole lot. And it didn't happen every time either. It was basically kind of just for the first couple first 2 sessions. But then I kind of asked her, and I was like, do you feel like you were having a bowel movement? She was like, no, she didn't know. But I also didn't do a lot of sensation testing in that area. But wherever I did do the sensation testing, it was intact, and she had good proprioception. She wasn't showing any problems with coordination or anything big like that. But no, I didn't really kind of consider that, and I didn't really read anything about that. I don't think there had a bunch of that stuff in the documentation as far as that goes. Yes, sir.
In your research, you talked about the standing frame for about 6 to 8 minutes. Did you see anything about like the optimal standing time to be able to, like, as far as be able to make a significant change?
Yeah, so I think I'd probably have to re-look at it again, but I think obviously it was longer than the amount that we actually did. I think the study group was, if I'm not mistaken, close to an hour a day. So obviously we weren't going to get that, but I think their protocol was like an hour a day for, I think, 5 days a week. So we obviously weren't able to get to that protocol, but
So it's definitely like an inpatient rehab setting.
yes, yeah. And I will share that with you too. Anybody else?